Manipal Hospital doing stroke fellowship under the Manipal University. So here I introduce my interventional guide, the Chief of Intervention Neuroradiology Services, Dr. Ullas Acharya. Sir, welcome, sir.
Yeah, hi, good evening, everyone.
So today we are going to talk about that carotid wall imaging. So first, let us see a hypothetical situation or real situation where a 65-year-old male, the known diabetic, who is having a recurrent stroke in one of the right MCA territory. On evaluation, his stroke blood workup for the stroke was normal, and MRI showing right MCA infarcts. However, the angiogram intracranial was normal, and the cardioembolic 2D echo, Holter, and loop Holter and workup was normal. So, the CV Doppler, there are non-calcified plaques in both right and left carotid arteries, and the left and the right side without any hemodynamically significant stenosis. It is the cause of recurrent stroke where there is no hemodynamically significant stenosis despite extensive evaluation. I think in this scenario, what next is a question that comes to everyone's mind, or every neurologist or every radiologist or intervention person that comes to the evaluation of cause of stroke. And there is a scenario now where we have to look beyond the lumen. Looking beyond the lumen, and there are the CV Doppler. If we see carefully, there are non-calcified plaques in the left proximal carotid arteries and right proximal carotid arteries without significantly causing hemodynamic stenosis. So in this thing, we need a certain images, certain sequences to study about these plaques. So with this introduction, I go into today's topic about the carotid wall image. As introduced, I am Dr. Krishna, doing fellow in stroke in Manipal Hospitals, and my intervention guide, Dr. Ullas Acharya, Chief of Intervention Neuroradiology Services. As we all know that carotid artery atherosclerosis, they are conventionally done by ultrasonography, MR angiography, and CT angiography, utilizes the luminal geometry and the surface irregularities to quantify the extent of stenosis. However, the trials such as NASTED trials, European trials, and asymptomatic carotid artery trials, that is for endarterectomy, they have used the luminal diameter as a parameter in quantifying luminal stenosis. Recently, due to the improvement in the imaging technology, and few of the radiology societies and neurology societies, the concept of luminostenosis have received certain criticization because there are the plaques that produce mild to moderate stenosis may lead to acute cerebral infarction. However, the HP sections from those studied arteries, carotid plaques showed erosions and disruptions in symptomatic lesions. And by this, we can say that the luminal narrowing may not be the sole predictor of the cerebrovascular events. And the three things: the degree of stenosis is a weak indicator of volume and extension of carotid plaque. And there are a set of plaque features can be identified by imaging, which are linked to the development of stroke. And these features can increase the risk of stroke regardless of the degree of stenosis. So let us see why we need for carotid wall, vessel wall imaging. One is to look beyond the lumen to study about the plaque morphology and identify the vulnerable plaque and risk stratification and role in the cryptogenic stroke. We see what are the features of that vulnerable plaque. The definition of vulnerable plaque is a plaque that is more prone for rupture. It could be the plaque irregularity, plaque ulceration, intraplaque hemorrhage, and the presence of lipid-rich necrotic core and intraplaque neovascularization. So the luminal morphology and ulceration, the wall can be smooth or irregular, which is a risk factor for embolism, and can be ulcerated, which can be more than 1 mm defect in the intima. That intraplaque hemorrhage, which can be rupture of plaque neovessels, they say that the diabetic and hypertension can precipitate this rupture. In the presence of fibrous cap, this can be as a thick fibrous cap and as thin fibrous cap. And the presence of thin and fissured fibrous cap is a high risk for rupture. And presence of lipid-rich necrotic core, more than 40% of the plaque, is a high risk for rupture. And also neovascularization. The degree of neovascularization is related to the activity of the plaque. The new microvessels grow into the intima, which have an immature endothelium, and they can cause rupture and cause an intraplaque hemorrhage, which is a vulnerable plaque. Come to the plaque remodeling, it can be either positive remodeling or negative remodeling. The positive remodeling, the dilation of the vessel with maintaining the lumen, whereas in negative remodeling, there is a narrowing of the lumen. Come to the prevalence of plaque rupture, presence of more luminal stenosis and presence of more lipid necrotic core, the plaque is more risk for rupture. The maximum wall thickness is one of the parameter which shows more the thickness of maximum wall thickness in symptomatic arteries. The high risk plaque is composite luminal surface and percentage lipid necrotic core of more than 40%. And these are some of the studies that have incorporated the vessel wall imaging, such as Eric Parsick and carotid plaque image in acute stroke, Chinese atherosclerotic risk evaluation phase 2, and Canadian atherosclerotic networks. Into the non-invasive modalities, we have the routine MRI, CT, 3D ultrasound, and molecular imaging. Into the MRI carotid, it is the most favorable non-invasive technique where we use 1.5 Tesla to 3 Tesla with dedicated surface coils. There is also multi-contrast carotid imaging, which utilizes the T1 sequences, T2 sequences, proton density, and time of flight, and they can help in characterizing the plaque and luminal stenosis. The contrast enhanced MRI gives about the tissue information and neovascularization. To the 2D contrast protocol, where we can guess T1 weighted images, T2 weighted, time of flight, and ampérage images, which shows that intraplaque hemorrhages. And the other sequence such as FFE and DSC, turbine spin echo and spin echo images, sequences can be used. And this is one of the image. The 76-year-old male with transient ischemic attack had detected 47% stenosis and the Nassett criteria. The MR angiography showing smooth narrowing of the vessel, ICA. And this is an MRI image showing the wall lumen and a thin fibrous cap and presence of an hyperintense signal in presence of hypointensity and the background of hypointensity, which inverts that plaque, and the focal enhancement suggests that inflammation. And we can also see the lipid core, and the black, the hypointense suggestive of calcification, which can be recognized on the plaque imaging. And this is a 74-year-old man, another case with TAEA. On the angiogram showed ulceration of the CT angio showed ulceration of the plaque, whereas that MR axial images showed subtle ulceration in the plaque, eccentrically located plaque, and coronal images can see the faint ulceration of the plaque. And one more, the carotid plaque in a 16-year-old man with TAA. You can see that carotid plaque, and this is an MPRAS sequence, rapidly acquired gradient echo. You can show that hyperintense signal, which is eccentrically located, which is suggestive of hemorrhage, intraplaque hemorrhage. If you see that luminal angiogram, the MR angiogram is normal. This MPRAS sequence detects the intraplaque hemorrhage. And this is a 73-year-old man with carotid valve stenosis 69%, showing that pre-contrast images showing that hyperintense signals eccentrically located, which is suggestive of hemorrhage into the plaque. It can be either subacute hemorrhage or presence of methemoglobin. There's a post-contrast showed that hypointensity surrounded by a thin hypointense ring, which is suggestive of an hemocyte ring. And the hemocyte sensitive suggestive clearly delineates that hemocyte ring, which suggestive of it's a chronic blood than the recent blood. Here the cross-sectional image of the carotid plaque, which shows that MPRAS sequence showing hyperintense signal, which suggestive of hemorrhage. In the snap image, we can see a small penetrating ulcer compared to the time of flight images. And the T1 weighted images and T2 weighted images, we can see the eccentrically located plaque, and in the T2 weighted images, DAR sequence inversion recovery, we can see a thin fibrous cap, and behind that there is an hypointense area, which is a necrotic core. And this is match sequence of MRI, which gives the comprehensive idea about the plaque composition compared to the routine conventional contrast protocol, where you can see that hyperintense signal on T1, which is suggestive of intraplaque hemorrhage, and hypointense on the gray blood sequence suggestive of calcification. Similar information can also be obtained on the conventional contrast protocol, whereas in case of presence of calcification, The T2 weighted images on a match protocol gives better idea, whereas the T2 on normal contrast image protocol doesn't give information about the calcification. There is a deletion of the fibrous cap. Either we can, as mentioned earlier, the fibrous cap can be thin or thick. We can see it. We can clearly see the lumen and the thick fibrous cap with the plaque here, and presence of thin fibrous cap. So these are the features: the intraplaque hemorrhage and lipid-rich necrotic core, plaque burden, and the comprehensive plaque information. The intraplaque hemorrhage can be detected by T1 weighted fat spin echo and time of flight images, and that MPRAGE images have higher sensitivity for detecting intraplaque hemorrhage. Whereas the lipid-rich necrotic core can be seen on T2 weighted images and post-contract T1 weighted images. It can help, these images can help in the quantification of lipid-rich necrotic core and delineation of fibrous cap. And the plaque burden can be easily demonstrated on 3D large coverage blood bag MR. And if you want a comprehensive plaque information, the match sequences can give about that. And whereas a 3D stab gives about a simultaneous IP detection, it also includes non-contrast enhanced MRA with simultaneous IPH detection. Coming to the imaging of CT carotid, it is most commonly used for the luminal stenosis and measurement. However, with the advent of multidimensional CT angiography, MDCTA, and dual energy CT, we can go for the plaque assessment. Here, MDCT uses an IV non-iodinated contrast, which gives at 4 to 5 ml/second using bolus tracking software. A helical mode CT usually performed. It can be rapidly acquired, and where there is no processing is required, and we can get the rapid interpretation of the results. Whereas in the dual energy CT, we require two different sources of X-ray and requires post-processing time, which would be usually less than 10 minutes. So this MDCT enables fast and accurate acquisition of vascular structure. It also gives information about the carotid stenosis, plaque surface, irregularities, plaque volume, and composition. The CT is more signal efficient and has higher spatial and temporal resolution. And this CT is routinely used to type plaques according to the Hounsfield units. The fatty plaques contains less than 60 Hounsfield units. The mixed plaque contains 60 and 130 Hounsfield units, whereas the calcified plaque gives more than 130 Hounsfield units. You can also get the information on plaque composition, volume of the carotid plaque, and volume quantification of plaque and subcomponents. So we can see the stiffness fibrous plaque, and you can see the mixed plaque and calcified plaque in the above images that ultrasound correlating with the CT. And this is a 75-year-old with TIA, where we can get the CT angio done. You can also delineate the plaque here. However, the cross-section area with automated software gives the information about the plaque, about the vessel. This red arrow indicates the lumen, and surrounding this black, this violet purple area shows the calcification, and whereas the green shows the mixed tissue density, and red indicates the lipid-rich necrotic core. And here is a 75-year-old man with history of TIA. If you get a CT, there is a discontinuity which is suggestive of ulceration, and that can be clearly seen on the image B, which there is a defect in the intima more than 1 mm. And this is an other image showing the calcified plaque with ulceration. On the dual energy CT, the calcifications are removed, and we can clearly observe the ulceration in the carotid wall. Coming to the plaque ulceration on MDCTA, you can see this is external carotid artery, internal carotid artery. You can see that extravasation of the contrast into the plaque, which suggestive of the ruptured plaque and plaque hemorrhage. And we can also see that extravasation of the contrast into the plaque. Come to the fibrous cap. It is very difficult to detect a fibrous cap on a CT, where we can see the lumen and cap here, the fibrous cap, whereas that you can see the contrast into the lumen surrounded by the fibrous cap. On CT, this is a 75-year-old lady with the right carotid stenosis, where the pre-contrast CT is suggestive of 48 Hounsfield units, the post-contrast CT showing of 86 Hounsfield units. This difference in Hounsfield due to Hounsfield units is because of the neovascularization. So using the pre and post-contrast images and comparing the Hounsfield units, and on the CT, we can pick up the neovascularization in the plaque. So compared to that MRI versus CT in the intraplaque hemorrhage, The CT is insensitive in detecting intraplaque hemorrhage, lipid, and fibrous cap because of overlap in the Hounsfield units, whereas MDCT with dedicated segmented software solves the issue and it provides equal or better results in detecting soft tissue components when compared with MRI. So MDCT is able to quantify the total plaque area, calcification, fibrous tissue in atherosclerotic carotid plaques in good correlation with histology. And the lipid core can only be adequately quantified on mildly calcified plaques. Come to the carotid remodeling. We can see that expansile of the vessel wall, which indicates that remodeling. And the expansile remodeling is a risk factor for plaque rupture. Coming to that molecular imaging, which is gaining the popularity, it uses either 18-FDG PET or fluorocholine. In a patient with stroke, we can see the right-sided stroke, we see the right-sided stenosis and left-sided asymptomatic stenosis. On the right side plaque, there is an activity pickup, which shows the plaque is active. On the asymptomatic side, on the left side, there is no activity pickup, which shows that the site is an asymptomatic plaque. Recently, I was told that molecular imaging is gaining popularity, and 18-FDG and 18-fluorocholine are the tracers used. It can also provide biological insight into the identification and classification of carotid artery plaques, especially those at high risk. Coming to that high resolution ultrasound, it is a standard imaging technique for first line diagnosis. It assesses the plaque composition based on the echogenicity. We all know that echogenic and hypogenic region is usually seen in lipid-rich necrotic area, and hyperechogenicity is seen in calcified areas, and it is also sensitive for it. And the for assessing luminal morphology and ulcerations, ultrasound is effective, whereas for intraplaque hemorrhage, it has low sensitivity. The fibrous cap can be suboptimally visualized, whereas on contrast enhanced ultrasound, neovascularization can be effectively seen. Coming to the invasive one, intravascular ultrasound gives a spatial resolution. It helps in identification of the fibrous cap or visualization of the fibrous cap, which may correlate with an increased risk of emboli. This is an ultrasound showing smooth plaque surface, regular plaque surface, and here we can see the irregular plaque surface near the right common carotid artery and on the entry into the internal carotid artery. We can also see on the color echo, we can see that contrast ulcerated plaque here and some amount of stenosis. And this is in contrast enhanced CT, which can visualize contrast enhanced ultrasound, which we can see the contrast in the lumen with some amount of faintly structure seen, which is suggestive of neovascularization. Usually that contrast enhanced ultrasound neovascularization correlates with the histology. And we can see that arrowheads, which is suggestive of irregular plaque and calcifications is seen on that ultrasound. And you can also see with the plaque with irregular surfaces that has been clearly marked on this image on ultrasound. And the suboptimal for that intraplaque hemorrhage that can be seen on that ultrasound imaging. So here is another case where a 34-year-old male presented to that emergency department complaining of bitemporal headache for 5 days and left neck pain for 24 hours, radiating to the ipsilateral mandibular and auricular region. You can see in the ultrasound, there is suggestive of some perivascular infiltrate seen around that carotid wall, and where we can appreciate the perivascular infiltrate, the arrowheads demonstrating. And there is also an MRI, which can be seen on non-contrast MRI as hypointense lesion. The contrast image showing that hyperintense suggestive of perivascular infiltrate around the vessel lumen. And we can also observe here in the sagittal cuts suggestive of an perivascular infiltrate. And this entity is recently described as a carotidynia or typic syndrome or phase syndrome, where there is a collection of perivascular infiltrate around the carotid wall. Usually it is self-limited entity, usually resolved within 2 weeks by treating with NSAIDs, and this can recur. Coming to the dissections, coming to the arterial dissections, the vessel wall imaging can also help to pick up the dissections. We can see it as a string sign clearly located on the axial T2 and fat suppression sequences. You can see the contour of the vessel, abnormal contour suggestive of dissection on MR angiography. And this is a string sign that is clearly seen on the digital subtraction images, and beard sign that is suggestive of dissections on digital subtraction angiography. So compared with MRI, the T1 fat suppression, T2 diffusion shows that high signal crescent sign indicating intramural hematoma. In MRI angio, that absent flow void or abnormal vessel contour can be detected. Whereas in vessel wall irregularity on digital subtraction images, we can see the sting sign and sting and pearl sign, that is a focal narrowing with distal site of dilatation, or rarely pseudoaneurysm formation and double barrel luminal intimal flap. Coming to, this is one of the image showing that carotid web where there is a projection from the posterior wall of that carotid into the lumen, and on that axial sequences T1 and axial sequences we can see the projection of hypointense projection into the wall. On the contrast images we can see that central hypointensity surrounded by peripheral hyperintensity, which is suggestive of a carotid web, and this carotid web is one of the cause for the recurrent stroke. Conclusion is the ability to, in this vessel wall imaging, the ability to look beyond the lumen using highly developed vessel wall imaging required to identify the plaque that is vulnerable or not vulnerable, and that paradigm shift is needed to move away from either to relying on the luminal stenosis for gauging of injury or plaque assessment for evaluate stratifying the risk for ischemic injury. And further evaluation in the randomized control trials will help to better define the exact role of the plaque imaging in clinical decision making. Current carotid vessel wall imaging techniques can be informative. Thank you. So here is one of the few important points about that carotid wall imaging. Any questions?
Yeah, so if I have to summarize what Dr. Krishna has just spoken for last half an hour. Yeah, so the question of luminal narrowing is always significant because we know the flow is directly proportional to 4 power of the radius. So when the radius reduces, the flow is going to reduce as such. But when the radius reduces, the velocity is going to increase. So these two informations are very critical, which we get through ultrasound, because velocity information is not got through the rest of the modalities, be it CT angiography or the MR angiography. So the velocity information is one of the crucial informations, which is additionally got using an ultrasound. So those two rules play a role while we assess the velocity and the luminal narrowing. So in carotid, anything above 70% is taken as significant. What vessel wall imaging does is when we talk about something of a 50 to 70% stenosis. And I think in clinical practice, we have seen that even with 50 to 70% stenosis, there are few recurrent strokes which keep happening. So that's why the concept of vulnerable plaques come in. And when we mean vulnerable, to keep it very simple, we can also remember it with the name itself of the vulnerable. So V standing for vascularization. So any demonstration of vascularization within the plaque would be a vulnerable plaque. U stands for ulceration. So you demonstrate ulceration within the plaque. That again is a vulnerable plaque. Luminal narrowing, as I said, around 70% and above is definitely considered significant. Echogenicity of the plaque. If it is an echolucent plaque, it is going to be more of a vulnerable plaque again. And then you have a follow-up, and you see there is a rapid progression of the plaque which happens. That is considered again as a vulnerable plaque. And any ability to move. So if there is intra-plaque mobility, that means to say probably there is a free-floating component, again increasing the risk of distal thromboembolism. So that's why it is a vulnerable plaque. So these would be the characteristics of a vulnerable plaque. And how we image it is what the various modalities would do. Obviously, each modality has its own pros and cons. The luminal narrowing as such is best picked up on the CT angiography study, but CT has its limitation when we talk about the say the vessel wall components per se. It can pick up calcifications quite well, so if it's a calcified plaque, yes, and the range of the Hounsfield units can give us a clue whether it is a vulnerable plaque or not. For example, less than 60 Hounsfield units, you know, we are probably dealing both with a fatty plaque. And so that is a vulnerable plaque. But the best vessel wall components is made out through the MRI. And we need dedicated sequences for it. And there are certain surface coils which are available with vendors, but obviously most of the hospitals wouldn't have it in particular for vessel wall imaging, which we can normally also do with the head coil. So in that, depending on various sequences and various intensities, we classify them as vulnerable plaque. So one of the most important clue is T1 hyperintensity. If we have T1 hyperintensity, we know we are dealing with an intraplaque hemorrhage. Again, that is a sign for vulnerable plaque. Now, we talk about fibrous capsule and those kind of stuff, which in routine clinical practice is very difficult to demonstrate. You need, as I said, dedicated coils, thin cuts to demonstrate those activities. So fibrous capsule, as such demonstration might be very difficult in our routine practices. But intraplaque hemorrhage is one of the easy identifiable factor to say it as a vulnerable plaque. Lipid-rich necrotic core, again, it can appear hyperintense on FLAR, but if you do contrast, it will not enhance. So that is one of the clues to say that it is a lipid-rich plaque. So these two plaques, if we find out on MRI, we know we are probably dealing with a vulnerable plaque. And if, say, there is a 50 to 70% narrowing with these features which suggest towards vulnerability, then probably we can have the best medical management being tried out initially. And if it still progresses, and those people become candidates for revascularization, even though it is not significant in terms of luminal narrowing. So to sum it up, ultrasound scores over by giving the velocity information. The CT angio helps us to see the luminal narrowing and calcifications, whereas MRI helps us to see the vessel wall. So we need to really see it case by case, what information we require, and then choose the best investigation for each individual case. So if it is, say, for a intracranial vascular imaging, the best modality is without doubt the MRI to show us the components. Obviously, luminal narrowing, you can do it with anything like the MR or the CT angio. Ultrasound TCDs are difficult, so that goes out of question. Whereas when we talk about the neck, you have ultrasound at your disposal at many centers. So that is there. CT angio is readily available in most centers. MR might be difficult. So ultrasound and CT angiography is quite enough to give us all the necessary information to say that it is vulnerable plaque or not, and whether it requires treatment or not. So probably that's the summary of the talk today. Any other questions? I think Dr. Krishna would be happy to answer it. And nothing on the chat box too. If there was
nothing on the chat box also. I think we can wind up with no questions for me.
Yeah.
Yes, sir. No questions so far.
Okay, sir.
Thank you, sir, for coming.
Thanks for the invite.
In future also, we would like to invite you for sharing sessions.
Yeah. Okay. Thanks for the invite. Yeah.
Thank you, sir. Thank you.
Have a nice day. Bye.
Shall we wind up, sir?
Yeah, yes, we can wind up. Sir is already.
Okay.